let me just take a moment and say how delighted I am to have this particular panel. One of the things that we have worked on is how do we convey to the larger community that includes all of our new partners, our partnerships that are still in progress and our partnerships that have actually happened. How do we communicate to the larger community what these partnerships represent and how they add value to the work that all of us do in our respective areas of endeavor? And so these three people represent one of the coolest things that anybody's done in data and the orchestration of data and clinical practice. And they're here to tell you about that. So payer provider, the signal and the noise, for those of you who are familiar with Nate Silver, you know that really just alludes to the difference between what you hear, what you pick up on, and what is actually going on. And so what I thought we would be able to do today with this remarkable group of people is to do exactly that, to separate out the signal and the noise from the really remarkable work that they did. So Kate Kinslow is going to open. Kate is the CEO of Aria. She is also the lead and chief integration officer that is enterprise-wide. And Mike, are you going to go second? No, we talked about this. You're going last. You are going to go last. So Mike is the CEO of Lumeris. He's going to go last. We switched up the order. Lumeris partnered with Aria to do this really remarkable project. And Blue Cross and my old friend Richard Snyder, who is the medical director of Blue Cross, he got kind of, can I say, kind of got dragooned into this. Railroaded into this. We had Mike Venera, who's the chief information officer, who was supposed to do this. But Rick has been with Blue Cross for a long time. He knows everything that there is to know, and including the important aspects of this partnership. So he'll go second, and then Mike will do cleanup. Mike, by the way, put us on notice that he was intentionally going last so that he got to reshape the impressions that all of you are left with. So he understands the importance of writing the history, so he's going to try and write the history today. But if you would please welcome these really extraordinary people who are doing really extraordinary things. And we'll start with Kate Kinslow.
That's funny. I said to Mike, since he wanted to go last, right after we're finished, we're getting up and walking out. so the person who'll get last won't even have anybody there. Thank you for having us today, and I really appreciate the time to share the journey that we went on with Aria and our partnership with Lumeris and IBC. And when we looked at this, this was about around 3 years ago. We were, as always, in the role that you have as leaders, we were looking at the landscape across not only the country, but what was happening within our region as well. And it was very clear that there were multiple changes that were going on. And I was just saying to my colleagues a moment ago that I was speaking to someone who was a friend of mine who's telling me that he never has time, who actually works here at Jefferson, to take vacation. I said, well, you're really crazy, because if you think things are going to slow down and that this is not the steady state of turbulent whitewater all the time, then you will never go on vacation. So in looking at the landscape, it was at that point in time, you had the Accountable Care Act, the SGR for the physician payment was coming down the road. At the same time, there was this incipitous rise of consumerism, and we started to see this. And it's interesting, I think, how many people in the room are healthcare providers? So a significant amount of you. Interestingly, my background is I'm a nurse anesthetist, so I came up through the ranks and was at the bedside for a very long time. And it's interesting that I feel that healthcare didn't realize that we had to think about consumers. That we didn't realize that although the patient obviously is one of the most important things that you do, it was not always that the patient was in the center of everything that we do. So in looking at the changing landscape, and then if you see on this slide, the outcomes that we were experiencing as an industry, if you look to my right, healthcare costs continuing to grow, yet the illustration on the left shows that the United States was doing very poorly. We're all the way over to the far right, compared to industrialized nations as far as outcomes. So in other words, we were spending the most amount of money and getting the worst outcomes. So we had high infant mortality rates, high cost of care at the end of life, and at the same time, high cost in ICUs. And patients were really not any better for it. And I looked at all of these things, the changes that were happening in the external environment. Healthcare is one of the most regulated industries outside of banking and airlines. And because of that, we are constantly beholden to what's happening in Washington. The large portion of our payment comes out of the government, and it is going to continue, if predictions come true to the way they are saying, to grow in that direction. And so regulations and what happens in Washington dramatically affects the field. So to that, we took it down to more of a micro level and said, what is happening in the population we serve? And in the map, you can see the areas that Aria covers. And it's Bucks County, Northeast Philadelphia proper, and lower Northeast Philadelphia into the Frankfurt region. There are three very distinct populations there. The Frankfurt organization has low socioeconomics, very mixed population, and a high density. Over 400,000 covered lives are within the zip code that that hospital serves. In the Torresdale area, it's much more middle class, high concentration of police and fire, but for those on the business side as well as healthcare providers, that gives you a fairly strong insurance base. And then Bucks County is one of the highest over 55 populations in the United States, even outside of Florida. So different needs, different things that this patient population was bringing forth to us. And we needed to be able to, because the major thing that you do as a provider is give care to your community. And you have to be a strong community asset in order to be able to do that. So based on the triple aim, and the triple aim is a concept that came out of the American Hospital Association, and we added another component to it, population health management. It's really based on the AHA's concept. How do you deliver care, which is the highest quality, the lowest cost, with the greatest patient engagement? And of course, from a business perspective, you know, that's the model that any business is trying to do. It's why Amazon is one of the most successful companies out there. Amazon has the highest customer engagement of any other company in the world. And that when you measure it by the index that they measure it, Amazon rates at about a 90. What do you think healthcare comes in at? 20%. So people believe that, you know, and I'm sure there's physicians in the room, that my patient will follow me. We believe, you know, we're Jefferson, our patients will follow us. The reality of it is our patients are not loyal to us. People will go back to Amazon. People don't necessarily come back to healthcare. And part of it is because I really believe over all of these decades, we have missed the mark on how do you deal with the patient. We talk about putting the patient in the center, but what does that really mean? So when we think about the triple aim, how did we move forward to look at novel and innovative ways in order to be able to do that? One of the first steps was through this partnership that you've heard about. We joined with Lumeris, as well as with IBC, and a group called Livongo and Allscripts, Allscripts as our EHR, to really come together to say, how can we improve healthcare across the continuum for the population that we serve? We are a relatively small organization. It's about 680 million, and we have very tight operating margins, around 1.5%. So there wasn't a lot of money for us to be able to say, you know, if we lose several $1 million, it's not going to matter that much. At that point in time, when all this was going on across the industry, oftentimes you would go to meetings and they would show you a slide, which was an individual on white water in two different canoes. And they had a foot in one canoe and a foot in the other canoe. And they would say, you know, everybody who's out in the audience, this is what your payer world looks like. You've got a foot in fee for service, and you have a foot moving from volume to value, and, you know, how are you really going to manage that? And our thought was, yes, that's correct. If you jump too fast in one direction and add a fee for service, it could have disastrous results to your organization. But at the same time, I kept going back to, what are our outcomes? What are our outcomes? And we, as an industry, are not providing the care, and it is not just an opinion. You saw from that first slide where we stand. So how do you work to provide better outcomes for the patients? So that was what the intention is when we all came together. So what all the individuals helped us to do is create a population health management company. Now today you say, well, that's maybe not all that innovative. A lot of people are doing this. But when you think about several years ago, that was something that from where I sit as the CEO, that most people really didn't want to touch. There were pockets across the country, as we know, all healthcare is local, that individual states were moving more rapidly in that direction. But here in our city, none of these mergers had occurred, and everything was very siloed in how we were approaching this. So we joined with these groups, and our first goal was to actually survive the transition. We didn't want to close, so that's very practical. We're a pragmatic group. We needed to balance our existing fee for service as we were going to be moving from volume to value. And in fact, a lot of payers didn't even want to have those kinds of conversations with you. We looked at how do you lay the foundation for getting value to the patient and changing the care model, because care models even today are very episodic in nature. They are not across the continuum. So an individual comes in and they look at the care surrounding what is the patient problem that they're presenting, and not thinking about what are the potential social determinants of your care after you are discharged and go home. One of the biggest predictors of how well you'll do from a healthcare perspective is your zip code. And that is what affects your ability to be a healthy individual or not. And unfortunately, that is very consistent with where we are in this country around education, because your zip code is also very predictive of how well you'll become educated in this country. So when we looked at that, and we looked at the areas that we cover, and it was why I told you about the various backgrounds, we needed to take an approach that was different for all three hospitals. And our second goal was really to succeed in value-based care and how to expand and provide the services and the supports for individuals to handle those social determinants of care, which are so predictive of where you go with your health into the future. So we created a population health infrastructure. We put forth the analytics because it's really very important. And I will tell you, that is one of the most difficult things, and it continues to be a challenge. And it's because of the disparate electronic medical health records that everyone has. Physicians has varying ones in their office. Healthcare organizations have varying. Within our system right here at Jefferson, not every hospital has it, just about has a different electronic medical health record. And to be able to bring everyone on a common platform is multiple millions of dollars. And so states are looking at how they can do that more effectively through health information exchanges. But at this point today, it is very hard to get the data and the analytics in order to make the right choices and help the patients. So then we looked at who are the teams that we need, what are the skill sets, which were different than what we needed in the past. You really needed people who could get into the community, who related to what was happening. So I'll give you as an example, in our Frankfurt neighborhoods, what we needed to do is to be able to have people who could go into the churches. We needed to have people who were reflective of the population, who understood the social mores and the cultures of that organization. You couldn't just send somebody in from Center City and said, here, go. They would have had no desire to talk to you. And so we needed to change our approach depending upon who was the population we were talking to. And then we needed to really look, and I think this is important for anybody who's doing that, what is the compensation model that you had in place with your physicians. Because if you don't have the same alignment with your physicians who are imperative in this, you are not going to be successful. The physicians need to be aligned with you lockstep, and they need to be actively leading the process. So another thing that we did is we put in place a physician governance council. So this was physician-driven, administratively supported, rather than the other way around. It should never be thought that administration should be leading clinical enterprises and doing things that interfere with the ability for the physicians to practice. And what we did is really, over years, start to see dramatic changes in the performance and the outcomes. If you look at the bottom of the slide, when I said we looked at the analytics, and if you can see that in the back, it was around breast cancer, cervical, and colorectal screening, medication adherence, A1C and diabetes, diabetes neuropathy, and osteoporosis management were the high areas where we needed to do better care of our individual patients. And so when you look at if the blue line is the improvement, so we were able to become a top performer with our partner IBC in their risk contract that they had for us. As well as the same time, we saw better outcomes for our patients, which is extremely important. And we had lower preventable admissions than we had had in the past. So again, along with the triple aim, we reduced unnecessary medical costs. Between 2014 and 2015, there was a 4% decrease in cost in our Medicare Advantage population. Now, there was a 1% increase on the commercial side, but normally that growth would have even been higher. So we were not only to manage better care, we were able to manage the cost of the care to those patients. And we also, which was important, were able to deliver greater satisfaction and alignment with the physicians who participated with us actively. And over 70% of the practices achieved incentive payments. And the way we set up the structure is that not only were the physicians financially aligned with us, but the greater the outcomes, the greater the incentive for the individual physicians. So, because we were asking them to change process flow, care models, doing care in their offices different than they had in the past, and to be able to align with us through their electronic medical record. So the key takeaways, it's truly critical, no matter what you're doing, is A, to set your goal and to make sure that your goal is the appropriate one. For us, it was about patient care and how we could improve the care of the population that we serve. You need to make sure you have the right team, and as you're looking for partners, to develop a trusted partnership with people who have the same incentives and the alignment as you. And I will tell you, both Lumeris and IBC through this journey, which has been several years, have been exemplary in being true partners in helping us not only in the good times, but in the times of challenge and struggle. You need to get the right data. That is extremely important, because without the data, you do not have the ability to change the care processes and ultimately give the information to the physicians that help the patients. And we need to engage the patients at all times, because it's the most important thing as we go forward in trying to improve care of the populations. So that's the summary of the case study that we did in this partnership with Lumeris as well as IBC. And with that, I'm going to turn it over to our colleague from IBC to describe a little bit of their perspective. Oh, I'm sorry, did you have a question before we do? Yep, sure.
Maybe it'll be answered, but what was the main? What was the main clinical change? An example of one of the clinical changes that both improved care as well as the financial outcome for the IBC and the practices. Just to put a little more
So one of the things that we did, and you saw Livongo up there as well, which is another group that we partner with. And so you take the diabetic population, which is a huge portion of the population across the United States. So we worked very closely. We first started it out with our employees, because we're self-employed, because you can make sure that what you're doing and setting up is appropriately, and helping to control A1C by giving individuals real-time information and being able to track that, and then giving them alerts, so pushing rather than pulling, so that they knew when they needed to take, their medication. And then we continued to follow up with them. We followed up with them around the ability to purchase their medication, because that's a huge problem of why people don't. Constant contact and calling and outreach. And you saw some of the examples, and the ability to manage A1C certainly came into much more of where we needed to be, which ultimately results in cost savings. Does that answer your question?
Just adding to that, I think the observation from us working together, both with Aria and as well with Abington, is that physicians often don't have the information they need at the point of care when the patient's sitting right in front of them to actually take the actions that we, all of us collectively, would want to take if we had that information. And there are many reasons for that. The reasons can range from, paper records are no good, right? I mean, and electronic records have limitations as well. But on top of that, in Philadelphia, not exactly sure for Aria, but in the center city here, about half of the readmissions are at different hospitals in the incident admission, and about 50% of our chronically ill, multi-comorbid chronically ill patients get care in multiple systems. And in the past, that data has not flowed to the point of care. So if you're taking care of one of those patients who has a specialist in 2 different systems, you don't likely know all of the information about them. So as we'll get into a little bit later, it's about bringing all this data together into one place and then feeding it to providers when they're with a patient, and feeding it to a care manager in the practice so that they can call and make sure people who have care gaps get in to close those care gaps, and to remind people to stay on their meds and all the other things that lead to these kind of better scores.
That's really consistent with patients, particularly chronic disease patients, getting care in multiple different hospitals. And the data, it was a recent study that was just put forth, indicates that they not only have worse outcomes, and it's not that the hospitals are bad, but it's this whole issue around the analytics and information, and shorter life expectancies than individuals who, you could keep them within a particular system and have the appropriate management of that care across the continuum.
So I'm going to go back before this started to my days in practice, which were paper records, and the real creative things of the day were problem lists and things like that tried to bring data to the front page of a chart. Not very effective. I'm sorry. Oh, I'm sorry.
You have to be
bring me over here.
You're being filmed.
I'm being filmed. Okay, sorry. And then I became involved in starting a physician-owned HMO out in Lancaster County, and I was introduced to green bars, and you remember green bars, right? So we would take, a pack of a green bar, it's just a giant report, and distill it. You'd go through it, and eventually you'd get it down to one little table that told a story, but it took you 5 hours. Not very effective at trying to change physicians' behavior when they're seeing patients. And so when I came to IBC 20 years ago, and yeah, I have been here a long time, Donna, the story, early on, we had all this data, but we didn't really know how to share it. And over time, we had more and more data, but again, we didn't have a vehicle to get it into the hands of the physicians. There was a gap between our data warehouse and the physician's electronic medical record as we advanced over the last couple of decades. And at the same time, now I'm going to jump forward, what we've witnessed, you presented a slide that showed the outcomes, the cost and the outcomes, right? I have a slide that I love to dangle in front of providers, and I am a physician, so therefore I can do it. But in Philadelphia, we have incredibly high utilization, an awful lot of units of service at a very high unit cost, we have, believe it or not, fairly average quality, not because there aren't centers of excellence, there certainly are, but if you look at the hospitals in this city, they look a lot like hospitals in LA and New York and other cities, so on average, most of the care is delivered in hospitals that look like hospitals in other parts of the country. So I say we have average quality overall, and satisfaction isn't so good because of what you talked about with consumers. Patients' experience is often disjointed. They feel like care is not well coordinated. And I don't think it's the fault of anybody maliciously or intentionally delivering that kind of care. That's what we designed the program with a fee-for-service mindset to deliver that kind of care. It's not intended to really bring people together and rallying as a team around a patient. So you can't read, I'm sorry, you can't read these bullets, but the three arrows heading up towards nirvana are high quality, cost effective care, read financial transformation, clinical care transformation, and member experience transformation. And the little bullets really are a migration from fee for service to pay for performance to increasing accountability and eventually global capitation for cost of care. And if you could read the bottom ones, they're really focused on the member, moving from uncoordinated care to having a much closer relationship with a care team, of which the physician is the leader of the care team, and eventually migrating on through cost and quality transparency to where the patients actually have a good experience in the care delivery system and we get better outcomes. And then to get there, this is a journey that we still see ourselves on. The clinical care transformation, which is the middle arrow, we have a philosophy we call engage, enable, and empower. And engage is to transform the reimbursement system so that there are strong financial incentives to actually take the time to re-engineer care delivery, to re-engineer workflows. And I'm going to use one example just to give you, and I'm working on this with another health system. We're talking about and I'm going to use fake numbers, or fake news or whatever, but if an average cost of a year of care for a class 3 or 4 heart failure patient is $50,000, and that involves 2.5 admissions, it involves a lot of professional visits, it involves lab studies, medications, post-acute care, home care, et cetera. And the 2.5 admissions result from the patient not being able to afford transportation to get to the doctor, not able to afford their meds, et cetera, et cetera. What we're talking about is saying we want to put a bundle around that patient for $45,000, and the system, I will put my people, my data, my information at the access of the system and work with them side by side to build a continuum of care that pays for transportation, that pays for medications if they can't afford them, and makes sure the patient has a care net around them, and we'll deliver the care for less than $45,000. And what's left goes back to the system, i.e. a strong incentive to deliver a different kind of care experience for patients. I think patients would like it. The physicians involved seem to like it a lot. And along with that, we're trying to introduce some technology to really simplify some of the barriers that physicians encounter while going through e-prescribing and then getting callbacks because things need pre-certification or they're not covered in the patient's formulary, et cetera, et cetera. So all to say, engage, enable, empower. Engage is about money. Enable is about bringing data and information to the point of care, and Jefferson, Aria, Abington are all part of Health Share Exchange, which is a regional HIE that we have here in Philadelphia, which is intended to do just that. It's to, in addition to the data that we're talking about here, which is moving huge volumes of historic and parsed data into the electronic medical record where it can be used by the physicians, there's also the need to know that a patient of yours is in the ER at another hospital right now, and how can you intervene to help that patient, help the physician understand the patient? How can we get real-time information into that physician's hand who's seeing the patient so they don't end up admitting the patient needlessly when you're the person that may know a whole lot more about the patient's history and treatment? So that's data and information. And then empower, finally, and Here at Jefferson, I have a nurse in the family medicine practice and another one in the internal medicine practice. And we're trying to find a balance between, obviously, small practices don't want our nurses in there. They don't have the room for them. They may not have enough IBC patients to warrant it. But in big practices, it may make sense for me to allocate staff to help make this transition happen, help it. So hence, Empower is about providing people to support it, part-time, full-time, whatever. And with that, we hope we can really change on that original graph that we looked at that showed the United States way out to the right with fairly low quality. We want to change that here in Philadelphia. I mean, if we can't do it, nobody can do it. We've got enough mental horsepower and bench research and clinical research capability in Philadelphia to deliver on the promise, I think. So at this point, I'm going to turn it over to the guy that made all the data flow.
Great. Thank you, Rich, and thank you, Kate, for the kind words. It really is an honor for me to just sit on the panel with Kate and Rich, because they represent leaders of two of the most influential healthcare organizations in the Philadelphia market. I'll ask the question of the audience: what's the total healthcare spend in the Philadelphia market? The annual healthcare spend in the Philadelphia market. Who'll take the bait? Just throw out some numbers. 10 billion. 10. I hear 10. Another number. 30. Okay, thank you. One more number. You got to have 3. 5 billion. It's $45 billion. So that was not a trick question. Just the gravity of that. I mean, Philadelphia is obviously a large metropolitan area, but one of 20 of similar size around the United States, and there's $45 billion of healthcare spend. What I would like to amplify on what Kate and Rich talked about is that one of my responsibilities as CEO of Lumeris is to spend time throughout the United States understanding trends that are occurring in the market that will either facilitate the growth of the great work that Rich and Kate have led or impede its development. And so I'd like to talk about 3 of these macro trends. There are about 85 healthcare markets in the United States defined by the government. At Lumeris, we are implementing the Lumeris model in about 20 of those today. I have the opportunity, I feel like I'm in all 85 markets every week, but I'm probably in 10 markets every week, 10 different markets, talking to healthcare leaders. I mean, it's a privilege and an honor for me to have the access to the leaders in the healthcare industry, as well as other industries that are going to affect healthcare longer term, such as technology. There are 3 trends that I'd like to comment about, macro trends. One is the effect of Trump care. You might be interested. I'll give you my perspective, which is one of probably 330 million perspectives on what is Trump care and what effect will it likely have. I'll take the risk and put some positions out on the table. Second of all, what are some really important market and technology trends that are going to affect healthcare and the model that's been implemented by IBC and Aria here in Philadelphia? And then thirdly, I'd like to make a few comments about what can we learn from other industries and how they have been impacted by market and technology changes over the last 10, 15, 20 years, and what can we learn in healthcare from those trends and the effect it might have on us. Okay? So three broad categories of macro changes. When I got the invitation to speak, it said on the invitation that I'll be speaking in the lobby of an office building in Philadelphia. And my first reaction was, that's kind of like being a sidewalk preacher, I guess, because people are going to be walking through the lobby, and we do have a fascinating sidewalk scene here. Did you see the guy with the red beard and the purple scarf? I mean, really cool. But but being a sidewalk preacher, it worked out for Billy Graham. He started off as a sidewalk preacher in Los Angeles. But first trend, Trump care. Because of, we owe it to our customers, we have to be, and partners, we have to be smart about what goes on inside the Beltway. I mean, personally, I would like to spend no time inside the Beltway. Some people live there and never leave, never want to go outside the Beltway. I live outside and would prefer not to go. But we have an obligation to spend time in Washington, and I do. I've had the remarkable opportunity to advise 3 sitting presidents around healthcare policy. I'm not sure why they were interested in my opinion. I'm really just a country boy, grew up on a small farm in eastern North Carolina. But for some reason, they thought I knew something. And in both cases, and all 3 cases, I got invited back a second time. You can normally get it 1 invitation. It's the second invitation, maybe you said something smart. I will make one personal comment. The least curious of the 3, Bill Clinton, George W. Bush, and Barack Obama, George Bush was the least curious. Nice man, but the least curious. The most socially engaging is Bill Clinton. I have never been around someone who could rapidly engage you on a personal level. And of course, and also be intellectually very, very strong. Obviously, President Obama, intellectually very strong. A little icy, slow to engage, very professional though. Trump care. What I have learned about politicians is that when it comes to making changes to social programs, they are very reluctant to take benefits away from voters. So therefore, I forecast that changes to Obamacare will actually come very slowly, because that's what politicians do. Even if they do make changes to social programs, and there's very little precedent for major changes to existing social programs. There's one I'll talk about in a minute. They tend to spread those changes out over a long period of time to make them acceptable to voters. And they tend to compensate those who are negatively impacted in the short term. And so the one example, which is pretty remarkable, was the reform to the welfare system in 1996, which was actually led by Bill Clinton. And it was implemented very slowly, those changes. So it was a Democratic president and Republican Congress implemented welfare reform. It's one of the few examples I can find where there's been major changes to a pre-existing social program. Now, the implications of those changes, they added work rules, they implemented a very rigid means test, and 20 years later, in 2016, 60% there are 60% fewer families on welfare than there were in 1996 in actual numbers, and the actual welfare benefit in inflation-adjusted numbers is 25% less. But it was phased in over almost 2 decades. So I think that's some indicator of what will happen with Trump care. Now, there are a couple of things I think we will see in the relatively near term. There was a strong movement through Obamacare to federalize health care. Medicare is already federalized, and obviously Medicaid expansion was all about federalizing Medicaid. I would argue that that may be a good thing, but it's not going to happen. Because you look at what happened in Medicare, that is in fact a single-payer system. And you're saying, wait a second, you're a capitalist, Mike. Why would you be in favor of a single-payer system? Actually, the government organized Medicare. There's this and implemented Medicare Advantage, which allows them to delegate responsibility for executing Medicare to the private sector for those consumers that want that option through a program called Medicare Advantage. And it has been enormously successful. So that was a case of public-private partnership. The government established the same rules for Medicare exist in every state in the United States. So if you come up with a model that provides superior results for Medicare populations through Medicare Advantage, you can implement the same program in any 50 states. Medicaid, we obviously know that's not the case because it emerged at the state level. And there was a strong attempt the last 5 years to federalize it through a program called Medicaid expansion. That will devolve back to the states, I predict. The Republicans and the Trump administration will devolve through block grants and basically blunt the sword of the federalization of Medicaid. The implications of that is that benefits long-term will actually be diminished. Costs at the state level will go up. Costs at the federal level will actually go down. and you will see enhanced work rules, you will see strong means test, and probably premium participation by Medicaid beneficiaries. Look at Indiana. Indiana is a model that I think that you will see extended to the federal level. In that lineup of Undersecretary Verma, Secretary Price, Vice President Pence, I think they're absolutely committed to implementing that change. And then, of course, the exchanges represented a federalization of commercial beneficiaries through federally run exchanges. And I think you'll see those devolve back to potentially state-run exchanges. Rich and Kate really interested in your perspective on that. So bottom line is that in the near term, I don't see Trump Care blunting any of these initiatives. And in the longer term, actually, I think it enhances them. So that's one trend. Okay, second trend, market and technology changes, systemic changes. I would recommend you think about three. One is data. As Rich pointed out, it's about information. We have created a fairly opaque healthcare delivery system where information does not flow easily from one participant to another. The results of that is that leads to inefficiencies. We attempts by, let me pick on Silicon Valley. It's easy to pick on them and they don't mind because they've got all the money. But so Snap went public yesterday, right? This morning, I guess they started trading this morning. So who bought into the Snap IPO? Go ahead and admit it if you did. Okay, great. So what's it trading at now? It's up, right? Okay, good. Data, we're going to see a massive shift in the transparency of data within healthcare. The bricks that Kate and Rich have been laying are going to bear enormous fruit as far as leading to a total re-engineering of the healthcare supply chain. I say supply chain in a healthcare audience, and people say, are you talking about the acquisition of latex gloves? And whereas supply chains exist in every vertical market. Now, the supply chain in healthcare is not linear because the human biology is not linear. But there is, in fact, a supply chain. And that supply chain is not optimized in healthcare. Supply chain has been optimized in every other vertical market. And I forecast it will happen in healthcare. Now, you've seen massive investment in consumer health apps over the last 7 or 8 years. The number of iPhone apps around healthcare, I think they're up to 15,000 in the App Store. The number of health digital devices, wearables. How many Fitbit users do we have in the room? Okay, good. Here's been the problem. Because Silicon Valley didn't want to or know how to engage this opaque data supply chain in healthcare, they're attempting to do what they do in every other market, and that is in-run the existing participants and go straight to the consumers. I mean, that's what this digital health movement is what it's all about. It was named the quantified self by Wired magazine in 2007. They said the future of healthcare is what we call the quantified self. And that's all that data that's coming out of your wearable. And now the problem is, 8 years later, we have this vast store of data that is completely unusable. It's not reliable, it's not absorbable, it's not aggregated. Okay, so, but on the other hand, the data that is being produced is enormous, and it's going to be enormously valuable. So the second technology trend that's going to deal with this unutilized vast store of data is machine learning and artificial intelligence. Fasten your seatbelts. Of the 30,000 engineers at Google, 70% of them are working on artificial intelligence. And it's already changing. All those messages you get on your iPhone trying to help you decide, telling you how long it is from where you are now to where they think you're going, based on your prior patterns, it's going to actually influence and control your behavior going forward. It's incredibly powerful. Okay, the structural changes now. You need artificial intelligence to manage all this vast data. Now, what Kate, Rich, and I have done in our collective organization is that it's very hard, but we're able to do it using some traditional technologies to integrate some incredibly powerful data sets, the claims database from IBC, the clinical database coming out of the EMRs, at Aria, script data, lab data. And for the first time, we were able to show physicians at the point of care a 360-degree view from a cost and a clinical perspective of what's going on with the patient. It's 2016, and we're just figuring out how to do that. How do you add this huge petabytes of data coming in from the wearables to that process? Ask your primary care physician, does he want to get a direct feed of your blood pressure readings coming real time out of your wearable? And he or she's going to say, no. What am I going to do with it? Artificial intelligence will be able to interpret that data and inform your trusted provider in the future, in the not too distant future. There are structural changes that artificial intelligence will make to our country and to healthcare in particular. And one is a reduction in employment in healthcare. Over the last decade, actual employment in this country grew by minus 0.5%. Healthcare employment grew by 23%. There was a flight to healthcare in 2008 from other industries that obviously experienced a major downturn and a slow recovery from the Great Recession. So it was a flight to healthcare. When I had one of my meetings with President Obama, he wanted to understand population health and how to drive down costs in healthcare while increasing quality, the triple aim. The conversation was all about the triple aim plus one. And he liked everything about what I was saying until I said, it's going to yield lower employment in healthcare longer term. You don't like that part. Politicians don't like. They're job creators. Name one politician that doesn't run on job creation. And we're now entering an era where I don't think any politician, other than the government funding infrastructure programs, can actually create jobs. So that is a positive trend around AI as far as our ability to absorb and create invaluable insights to drive to the point of care and to improve decisions. Because what we found is not just financial incentive that drives behavior in healthcare. Don't ignore it. But if people, high-quality people, are provided information they didn't have before, they make better decisions. And you got to drive that information to the point of care. Third trend, we are now shifting into a model that actually truly funds preventative health care. Rich has labored in a model that was put in place 80 years ago that said that health insurance was a one-year contract. Every one of your members could leave IBC in 12 months. So tell me why Rich would want to invest in his members knowing that the return on that investment would likely accrue to another organization because the member decided to go somewhere else at the end of 12 months. Thank you for making an investment in my preventative health care. But you didn't capture the return on investment. I think what Kate and Rich have built is a model that incentivizes consumers and members to stay in the model long term, even though it's a one-year contract option, because they're getting such great health care, they actually won't leave. It's called persistency. And with that long-term persistency, Kate and Rich can afford to invest in those who are currently healthy to basically reduce the long-term cost. So preventative health care is now becoming a reality, not just a marketing term. Final macro trend. What can we learn from other industries? Kate mentioned Amazon. Amazon was created, certainly by Jeff Bezos, but it was really created, and that model was created because for 15 years before Amazon launched, when the internet became pervasive in 1995, 1996, the manufacturing supply chain around the world committed itself, both the retailers, those who face the consumers, and the manufacturers who built the products, they committed themselves to something called ERP, Enterprise Resource Planning. And what that was is the manufacturers didn't want to build products that consumers didn't want to buy. So they wanted direct access to what was happening on the shelves. And then, of course, the retailers didn't want to get stuck with unsold inventory. So they wanted just-in-time manufacturing because they didn't want to carry the inventory cost. So they integrated their data sets using proprietary technologies called ERP. And along comes the internet, which basically took that data and made it transparent and available to everyone. And Amazon plugged in a superior consumer experience into that vast river of transparent information and essentially disintermediated all the inefficient players in the global supply chain. So in healthcare, fasten your seatbelt, because once the data gets rationalized and integrated, the only players that get to play in the healthcare supply chain are ones that deliver competitive advantage around cost, quality, service, and availability, just like any other supply chain. That's going to be great for our country. The quality of care will go up, the cost of care will go down, the consumer experience will improve markedly, but there will be a lot of dislocation. But I'm an optimist. You want to be on the side of the winners here, so you've been forewarned. Thank you.
Well, thank you all for that extraordinary presentation, everything from the level of detail to the political speculation, which of course, we started that conversation earlier about what that might look like. So I'm sure that there are a number of questions that people want to ask. So, but just as a point of personal privilege, I want to pick up on the question on Trump Care. So we know that the new HHS secretary is a physician. I assume that's going to inform his thinking. And he's already made a few statements about how he intends to move that agenda forward that represents the president's agenda. Can you say a little bit, any of you, about how you think that's going to impact your work in this specific area?
Well, I would say not at all.
Okay.
Because when you heard Mike finish, that really is, it doesn't matter who is the president or what legislative endeavors come down. As a healthcare provider, as an industry, we have to provide access. We have to understand it is about the consumer. It has to be empathetic care, and it has to be high quality at a low cost. Because if you don't have that value proposition, I agree with him 100%, and it is what Amazon did, that you are not going to be able to capture people. So it would the only thing that I would say, if we were to get into a single payer system that was managed by the government and they started to drive care to different places, that could be a differentiator. But I also agree that change happens slowly in Washington based on the marketplace. Even if we move out of portions of the ACA, I think our goal and our strategy needs to be the same.
Yeah, in terms of what could Trump Care do to us, I mean, we worry a little bit about things like the elimination of the individual mandate, which in effect can allow the healthy people to default and not buy insurance, making it harder to keep control of the cost for those who need it and who are ill and have chronic conditions. But in terms of the journey that we're on, the arrows that I put up there a little bit earlier, I really don't see us changing direction. We actually have been invigorated by some of the work of the last administration, especially with CMMI, opening eyes, ears, and hearts to change that we didn't see in prior decades, a willingness to change the model for reimbursement, a willingness to change who's accountable and how you manage patients. So we see a willingness on the part of providers to really do things very differently. And I, for one, have a passion for transforming the experience that people have, because ultimately that's really important to us as an insurer. They don't stay because of we're the close to the cheapest or the cheapest. They come and they go based on their experience, and some of that is beyond my control and beyond Independence's control. But we think that by the journey that we're on today to work much more closely with providers, we will actually, in the end, have a stronger product, a stronger sense of brand, a stronger sense of working with you, having a partnership with you as opposed to just a relationship.
The only thing I'd add is that when the Affordable Care Act was passed in March of 2010, I think the Republicans kept referring back to Nancy Pelosi's comment about don't read it, just vote for it, and because it was 1,900 pages. But in the back room, when it was drafted, there were two major, what appeared to be unintended consequences that were actually deliberate, and would not have been supported by Congress had they fully understood it. And that was what was built into the Affordable Care Act was a shift of risk to providers and more cost shifting to consumers. And from a behavioral economics perspective, that's exactly how you make markets work efficiently. Now, it takes a long time for those benefits to accrue, and there's dislocation in between. But had they gone public and said what Democrat would have voted for, the Affordable Care Act, and says the primary objectives here are to shift risk away from corporate America to providers and to shift more cost to consumers. But that's exactly what happened, and it was actually necessary to get behavioral change to start aligning around a more efficient, higher quality delivery system. So Obamacare was attacked for not caring about cost, not focusing on cost. I think it was incredibly focused on cost, but the benefits occur over a long period of time.
Thanks. So just a quick note on that comment on legislation. You know what they say about it. You don't want to watch it or sausage being made. It's not a pretty sight. But I also I just want to make a point on the subject of how Obamacare, during the Obama administration, I think what they tried to do was to not replicate the errors that occurred on the Clinton administration's watch when Hillary was trying to advance a new assemblage of legislation that would fundamentally change care. So if you recall, she had the team that was set up to structure what that was going to look like, and they had lots of meetings, and then there were lawsuits. You have to let people in, and it was all created external to Congress, and then Congress was expected to pass this bill. And of course, that never happened. And the Obama folks, on the other hand, said, all right, we're not going to make those mistakes. What we're going to do is we're going to say to Congress, these are the principles. You give us a legislative package that satisfies those principles, and that's what we'll pass. It just turns out to be a different set of mistakes in many cases. And so I think there was a lot of really good stuff embedded in there. But again, 1,900 pages. There's always going to be a surprise. So I just want to sort of note that for the record. And I know there were more questions back here. Yeah, back here.
Thank you very much for a great talk. I appreciate your thoughts. I just came out from D.C. myself, and I know that the place is in flux, as you all know. But a question to me. So I'm happy to hear you say about transparency going forward, and the data be transparent. Is the same going to be? It seems to me that the one person missing from your panel is the pharmaceutical companies. Is the same kind of transparency? Will that happen with the cost of drugs and with the pharmaceutical industry?
So let me just take responsibility for the one person not being there, because they didn't pick the panel, I did, and it's in part it's just in part because these people work together on this specific project. So in your defense and by way of explanation, but please add some thoughts.
Yeah, I think that there will be enhanced transparency. It's going to be really hard. And for those of you that aren't terribly familiar with you talk about supply chains in the between the pharmaceutical firm, the manufacturer, and the patient are a laundry list of parties that are skimming a penny here, a penny there, a dollar here, a dollar there. I do think that there will be change. I mean, we've heard that there must be change, and I know we are driving very, very hard to change how we pay for drugs, how we negotiate for them, how we position them on formularies. And I'll use a real-life example. You know, there's an old drug that was available when I was practicing called metformin for diabetes, and it's cheap. It's pennies, you know, but if you want to take it once a day in extended release, then you're getting up into the low thousands of dollars for a year's supply. And I'm not going to name the name. There's a pharmaceutical company brought out a new brand that's $98,000 a year, has no significant advantages over the alternatives, brand and generic, and they brought their own generic out at $88,000 a year. And these numbers are relative, they're ballpark, depending on the circumstances of the patient's coverage. And there is absolute, I mean, that to me is abusive. And so what we have done, and the provider community has embraced this, is we bring that information to providers, which drugs are priced in such a way that it highly disadvantages the member, because members in a lot of cases are paying a percentage of or a different copay, a very high copay for those high-cost drugs. And it's just unfair and immoral, but they do it anyway. So we have been actively reaching out to providers, and Jefferson, as an example, was happy to take those drugs off their drop-down screens in the EMR so that you can't prescribe them. You could if you wanted to manually write a script, but at least it'll help to protect both unknowing providers who don't know the actual cost and patients from the impact of those kind of costs. Because ultimately, as a payer, all we are doing is taking the risk and spreading it across a population. So when you think that we have large margins, you know, last year we lost $54 million, and that was on a book of $15 billion. So, you know, if you're off by a percent or two in predicting what it's going to cost for healthcare, which is rapidly changing, you can be underwater very quickly. So, long story short, I think there will be some changes, but it is a very complex industry and very, very hard to unravel the relationships because of all the parties involved. I don't know if you have any other comments.
Okay.
No, I agree with what I think that, you know, and Ted, you certainly know in the hospital how we're trying to control the cost of pharmaceuticals. You know, one of the discussions is around how do you move to a single formulary. I mean, when you think about some of the countries in Europe and, you know, that the formulary probably overall in the entire country has a handful of the drugs that we do, you know, it does definitely drive up the cost, not only for the organization, but the consumer. And, you know, I do believe that prior to the election, there was quite a bit of discussion of it, you know, in the Beltway. There is not as much now. And I think that there are, it was not on, it appeared, to me at least, on President Trump's agenda. But I do think that there are several members of the House and Senate who clearly know, you know, you're involved in the Medical Society, I'm on the Hospital Association, and the Hospital Association is definitely going after the high cost of drugs and the ability to manage it more, because as you just brought up a moment ago, Rich, there are drugs that are out there that, you know, have been on the market for years, so the R&D costs have been well paid for, and they're, you know, EpiPens, look at the cost of them and the rise of that. So I think we're going to continue to see much more of this, but it is a complex question.
The only quick thing I'd add is that when you set aside the opportunism in the specialty drug area, and I think the market will sort that out, but the drug industry is not the evil empire, and but there has been a somewhat unspoken agreement between American society and the drug industry, is that the American consumer would essentially pay higher prices than the rest of the world to essentially fund innovation and research and development. And that's been in place, that understanding, for 50 years. And the idea is that countries that can't afford what American consumers can should have access to the same drugs as we have. Now, that's now been abused. And so I think that market forces, as well as our politicians, will make incremental improvements in that economic disparity between what American consumers pay and now consumers in developed countries, wealthy countries such as Canada, pay. They pay it. Everybody says, well, go to Canada and get the same drug. Well, that's because they've got regulations there that limit the price on drugs we don't have.
I have a question. What future market and technology trends and innovations will have the most impact on healthcare transformation?
I think the market, the two things that I would say that I alluded to here a little bit that'll have a big impact is a continued pressure on both providers and payers as we start to come together. Providers becoming payers, payers becoming providers, but in our case, we don't really want to replicate what we have in Pittsburgh, an all-out war. So instead, what our approach has been, let's partner, let's work together, let's leverage our resources and your resources, let's marshal them to deliver better care. Now, that's great. That's a nice thing to say, and it's great for the contract people and some of the clinical leadership to get in a room and hash that out. To drive that down through the rank and file, everybody in the system who's caring for patients, you've got to change the technology that we're all working on. We've got to bring data to the point of care. We have to evolve the delivery system to include new kinds of partners. We have to get away from thinking that paying for health care is only paying for health care. It's unfortunate that I can't pay for transportation for patients who live in West Philly and North Philly in the transportation deserts that exist, where there aren't really readily available bus routes or trains. And yet, government regulation would require that if I offer it to poor people, I have to offer it to rich people, and that makes it unaffordable for all of us. So we have to start thinking very, very differently from a policy perspective, how we work together. I think the contracts will drive that kind of change, but the technology that enables you as a practicing physician or an administrator to efficiently and effectively change what you do it's going to require new technologies that we don't yet have. And you mentioned machine learning and AI. We've learned a lot of interesting things from looking at our data with machine learning, such as if you have a poor credit score and you have heart failure, your likelihood of admission to the hospital is 3 times as great as if you have a good credit score. And intuitively, if you think about it, it makes sense because you're really talking about ability to pay for stress factors in their lives, et cetera. And it's those kinds of technologies that are going to really change how you target patients for interventions. I think you alluded to that, Mike. So I think contract models and technology are really going to enable this kind of change. I think you guys are fundamentally ready to provide better coordinated care. We just have to make it easy.
Hi, I have a question. My name is Glenn Ottinger. Question relates to artificial intelligence and how you think or envision artificial intelligence reducing medical errors and the costs associated with those errors.
Okay, I teed up the subject, so I'll make the first attempt. Let me just give you some examples. I try to spend a reasonable amount of time kind of rummaging through Silicon Valley to see what they're working on out there. Because occasionally they get it really, really right. They get it wrong a lot, but that's the beautiful thing about Silicon Valley. There's no fear of failure. And one of the somewhat stealth projects that's underway right now is that the former head of artificial intelligence at Google left to do a startup. And so he and I started having conversations, and he says it's in healthcare, and then that led us to a longer conversation. And what he has done is that he has built some storefront clinics in San Francisco. And then you basically, it's like concierge medicine. You basically pay a flat monthly fee. I think it's like $150. And then you can go to that clinic anytime you want. And and when you walk in, you go through multiple body scans. It's just part of the process. Before you even see the receptionist, your full body scans, and then there are primary care physicians there that then will see you after they've now gathered this real-time digital assessment of your body. Now, those primary care physicians believe that they're part of the leading bleeding edge of the next generation of healthcare. But what he's also doing is he has surrounded those primary care physicians with his technologists, and there's one-way mirrors, and he's observing everything that the primary care physician does. Because the primary care physician is actually the most complex job, because they treat everything from a sprained ankle to maybe a cancer diagnosis, whereas the specialist is more narrow. Sophisticated, but narrow. And his goal is, in 3 years, to essentially capture everything a primary care physician does in artificial intelligence. Will he be successful? I don't know. But if he's trying, you can assume many more are. So are we on the verge of a doc in a box? I don't think within 5 years, but take a 10-year view, maybe.
I think, I just would like to comment on that question a minute. I think artificial intelligence, and I agree with you, is going to have a dramatic effect, not only on this industry, but on multiple industries. And what you do need to do is to just watch changes. I mean, who would have ever thought a couple of years ago that people wouldn't be going to banks today? Who goes to the bank today? They're just about, useless. But when you think about, artificial intelligence, and I was just at a meeting last night, ability to study the way people's voice patterns and be able to predict whether they're going to get cancer, or how you type on your devices, what diseases that you will develop into the future. So there are really a lot of predictive modeling that you can use to be able to change and deliver care in a different manner. But I would suggest to all of us that I don't believe that it will ever be replaced totally by human beings. And part of it is because care is really about two people. And I don't think we can underestimate that relationship. Certainly people want to have access and fast. But if you're being diagnosed with something really terrible, I don't know that what you want to do is talk to a machine. So I just think that we can't underestimate that as this develops within our industry, that we need to continue to think about how do we work more effectively in teams, how do we understand the situation around some of the processes that are put in place in care delivery models that create inefficiency and errors, and how do we fix them.
And just two short anecdotes. One company across the river here is working on a software that they embed in Epic at a local hospital that takes all of the prescription information on that patient and compares it to black box warnings, contraindications, drug-drug interactions, all the things that would be relevant when a physician is prescribing. And it shows the physician, whenever they're writing a script for the patient, it bounces the new script off of everything the patient's already on. That could be one example of how artificial intelligence can help physicians manage massive volumes of data that are growing rapidly every day, well beyond the ability of any person to read and understand. A second one is to make life easier for physicians. There are a couple of companies in the city here who are working on and will soon go out with a prototype of AI-induced preparation for a visit. If you want, not everybody who goes to the doctor needs to go to the doctor, and certainly, half the time that you go and follow up, it could be managed in some other way. And this software is basically a front end, kind of like for you're looking for a house, you go to Zillow and whatever, and if you have an issue, within a fairly short list of questions, they really focus it down. They use the electronic medical record data from your history to bring that into play and mash it up against the new symptoms that you have, and then suggest to the physician, here are the things that we think might be in play, and a treatment plan that you might consider. And for a doc who says, oh my God, it's Mrs. Smith again, she's got another UTI, yes, I want to do that. It can all be taken care of electronically and out, without human intervention, so to speak, other than to give the okay to treat. And for a more complex situation, it prepares a lot of information for the physician when they see the patient. So those are ways that I think, you know, a busy physician could be advantaged by using AI.
Hi, thanks for a great panel. Yeah, I really actually, in a lot of ways, am intrigued by the Amazon model and analogy. But when I start really thinking about it, in my mind, I guess a little bit of disconnect, or I guess a question comes up from the fact that Amazon made me a better consumer. It didn't stop me from being a consumer. It makes me a faster consumer, and it's more convenient for me to be a consumer. But at the end of the day, I'm still having stuff shipped to my house that I need, that I would have had to spend more time and resources getting. And maybe my choices are being a bit influenced, most likely. But hospitals see patients, and we're still only talking about patients. The verbiage hasn't changed. The entire time, you know, the panel was speaking, we were talking about patients, but really fundamentally, we're talking about stopping people from becoming patients. And so I guess it's a two-part question. One is, what kind of services are we going to provide in the future versus what we provide now, which are reactionary, you know, in a more tangible sense than just preventative? And in another sense, I guess my question is, are we raising a new generation of medical care providers that are prepared for this challenge? And if we aren't, how do we start doing that?
So I would tell you to your second question, I would say the answer to that is no. I think that, you know, as you look at healthcare, more and more of it will be moving out into the community. And more, you know, regardless if, you know, more surgery will be 24 hours, more recovery will be in the home, more rehab will take place at home, and you will see the care being delivered in a very different way. So I think when we think about the educational component, we need to think about how we're educating people differently. I have had opportunities to go out with a lot of the home health care nurses, and I'm telling you, it's a very different ballgame that when you're trying to figure this out in someone's house and all the commensurate problems that are going on within that home, and you're dealing with it individually. And so how are we changing the education to work with technology to be able to have more real-time support for people? And how can you help to identify the various needs? And the other thing that I think that we need to do is, and you see this in other industries, and why I said a while ago, I think you need to watch what's happening, is there needs to be, and Jefferson is doing that with their Institute of Emerging Healthcare Professions. The fields that are there today, you know, we'll continue to have physicians and nurses, but there are going to be other caregivers that are very different than what we are educating. And we need to get out in front of that, and people who are in those roles that might become passé need to figure out how they can reinvent themselves.
The only thing I would add is that obviously the home is the lowest cost venue and the most convenient venue for the patient. And Alexa is going to have a lot of information to share, but Alexa can't put her arm around that patient. So it's going to be a merger of those two very distinctive value adds. It's more than just information, it's empathy, and maybe Jeff's working on a robot that can be empathetic and can put that arm around the patient, but not right now.
Rick, do you want to follow up? You good?
I'm good.
Okay. Well, we have time for one more question.
Thank you. What is the real barriers that prevent payers and providers from collaborating to improve outcomes?
That's a great question. I wish I knew the answer to it. There are a lot of answers, I guess. I think trust is one that has gotten in the way for many years because it was, you know, the contract people, the business people on both sides are off somewhere negotiating a contract that's focused on we want the best deal and you want the best deal. And sometimes there's room to give in one place or another, but it largely happened out of view and out of mind with relation to the clinical side. And So clinicians are surprised and often don't know much about the terms of the relationship between a payer and a provider. They may hear that, independence is friendly, and this was a fun project that we did together that's ongoing, but not really understand what happened there. So what I had talked about a little bit earlier, I'm actually trying to reach out and be completely transparent, try to be transparent about what costs are, where care is delivered. And the information that we've been giving to both Abington and Aria through the Lumeris tool has essentially provided transparency around cost and quality data so that the docs actually have information that they don't have in most of the other systems around here. The one exception being Tandem has had a group of 500 primary care physicians have had access to that kind of information. I think the next big barrier that we have to overcome is bring the two together. If clinicians are not at the table when the contracts are put together, it's really hard to imagine how you could go to you and I as physicians working together to build a bundle that encompasses a whole year of care for somebody with diabetes or heart failure. If the contract people aren't sitting in the room next to us, understanding what those costs are and how do we make it flow through the claims systems and other systems that we have to work in. So it's all about, I think, trust and all about partnering in a different way where you've got to get the right people into the room. So it's data, information, and people.
I think one of the biggest barriers that I see, and I recently, a couple months ago, we just finished the work, sat on a committee for CMS, and it's across the country, so I'm not just speaking about this in our geography, is data. There is a real reluctance to share data, and it's not only from payer to provider, it's also provider to provider. When, a moment ago, the Health Information Exchange was brought up, and it's been a struggle in the state because many of the individual hospitals that are part of it are worried about their data being shared with other hospitals and the proverbial, you're going to steal my patients. So the way I look at it, and what I was really pushing on the CMS committee, is that Jefferson, IBC, Penn, we don't own any of that data. The data belongs to the patient. And I think that if we would start to think about that differently, then the data would become much more transparent because the data isn't our data. And truly, I will tell you, and I saw this in just this little microcosm that we discussed with you today, if you have the data, you can make dramatic changes in the outcome of the patient. And I think that is not only individual organizations, but as people in the United States, we need to push for that data is mine and no one else owns it, because that's how we'll get true transparency.
What I would add is that a key word here is collaboration, and you can't have collaboration without trust, as Rich said. So I think the human factor is likely the biggest impediment, but also the biggest opportunity. The industry-wise payer-provider relationships were set up decades ago as an adversarial relationship. And so cultural change has to occur to supersede that long history, and I think it's happening. The shift to value-based healthcare means different things to different participants in the supply chain. We've seen massive consolidations of hospitals and physicians. You've seen that here in the Philadelphia market. So why is that? It's because their economics are driving it. The economies, the need for economies of scale, because if you're looking at it from a health system perspective, value-based care is a nice word for cost restructuring. In other words, costs are going to have to be restructured, as well as the products and services are going to have to be rationalized, and that needs to occur over time. That cannot occur without a collaborative payer involved. And so the providers in this country have to identify collaborative payers for all markets, Medicaid markets, Medicare markets, commercial markets. And if they can't identify collaborative payers, many are trying to create their own. like 60% of all the new Medicare Advantage plans launched in the country have, in the last 5 years, have been provider-sponsored plans, which is, to some degree, a statement of failure, the inability to form collaborative partnerships with payers who are already in the market. What I would like to do is to applaud Kate and Rich personally and corporately, because what they have done with this model that is now functioning in a very collaborative partnership, we're talking about the need to change both a new business model and a new care delivery model. That can only occur in an organization where that there is committed and courageous leadership, because you're essentially cannibalizing your old model. That is the toughest thing that leaders and organizations are called upon to do, is cannibalize a model that has apparently worked for a generation or more. I am not courageous, because in launching our company, we didn't have to cannibalize the old model. We started as a new company with a new model. They had to take responsibility for the risk associated with changing things that worked before to try to get improvements on a large scale. The characteristics, there's a joke in the technology space that is biblical, and it says that, you know, in Genesis, God was able to create the earth in 6 days and rest on the seventh day, and the reason is he didn't have an installed base. Kate and Rich have very large installed base, so how do you transition to a new model of care and, at a minimum, do no harm, and obviously for the opportunity to actually produce better outcomes? So the characteristics that we at Lumeris observed in these two organizations and these two individuals was courageous leadership, an incredible strategic focus, because this is a long-term game. You got to take the short, medium, and long-term view, and an ability to partner successfully. That's easier said than done, because if you're a good partnering organization, you can take advantage of intellectual property from many different organizations, so you don't have to replicate it yourself. And I think this is an example of that. So that strategic focus needs to come along with a great sense of urgency. And I wanted, when we got involved 4 years ago here in Philadelphia, we had spent 5 years trying to perfect a new model of care delivery and a new business model to finance it in the St. Louis market. We thought it would work outside of St. Louis, but we didn't know. So I'd like to thank Kate and Rich for taking a chance on our company and bringing this model into the Philadelphia market. So thank you all for your kind attendance.
I can't come up with a better ending than that. So thank you, Mike, for wrapping it up so nicely with those lead points. And I just want to point out that these are three extraordinarily busy people, and we were just so lucky to capture their time and have them talk about this really cool initiative that they put together. So Kate Kinslow, Dr. Rick Snyder, Mike Long, thank you so very much for being here.